In this video, we'll be learning about failure to thrive as a concept, how we define it, and a couple of etiologies to help build your differential when you see a child with failure to thrive. Interestingly, this is a very common condition we see in pediatrics that can be sometimes a little bit elusive in a way where we don't know how to define it. There are a lot of different etiologies, and it can be sometimes tricky to kind of pin down what exactly is causing failure to thrive. So in this video, hopefully you'll learn some kind of tips and tricks on how we can classify failure to thrive, as well as some treatment and prognostic factors that are important for developing children. We'll first start off with some definitions of failure to thrive. This is pretty interesting because there's actually no real set criteria for failure to thrive, especially in the literature. There's no real set consensus criteria established by the American Academy of Pediatrics or the North American GI Society. There are common sort of criteria that we like to that may fit certain individuals or certain children, but there's no real, again, set criteria for failure to thrive. But there are some common ones that I'd like to go over now. So, for example, if a child is less than the 3rd to 5th percentile for weight for age. And again, these kind of ranges are a little bit tricky to narrow down, especially since there's no criteria, like I said. So when we look at the weight for age for a child based on their growth chart, if they're less than the 3rd or to 5th percentile for their age, this is pretty much classified as failure to thrive. And then secondly, we have either if there's a weight deceleration past 2 major percentile lines. And obviously you can see that these criteria differ in a way in that the first one, you only really need one time for a child to meet that first criteria, whereas the deceleration, you need multiple occasions where you're tabulating results based on the child's age or based on the child's growth, essentially. So it can sometimes be a little bit tricky to kind of pin down what exactly is failure to thrive. But put simply, failure to thrive is the lack or inadequate weight gain, inadequate weight gain depending on the etiology of the condition. I'll now point you to this growth chart here. This is commonly what we see in the chart for kiddos when we're seeing them at the clinic or in the hospital. Typically we have here the length of the child at the top, and then we have the width at the bottom for the child. Again, this is measured over time. As you see, the child's age in months is on the x-axis. So I'll kind of point to starting with the weight for children. So for example, this child pretty much started at I believe it's the 10th percentile line, and has made some good acceleration here. But then once they get to about 6 months of age, they start decelerating, and by 15 months, by 9 months, they're well off the curve and continuing to flatten. On this weight for age curve. And that's sometimes a term we like to use, flattening of the curve. That's one way we can kind of discern that this child is failing to thrive in a way. So hopefully this was helpful to kind of run through what exactly a growth chart looks like. And maybe I'll make a video in the future about growth charts, how we kind of take those into consideration for a child. One thing I forgot to mention as far as kind of definitions of failure to thrive, there are different growth curves for children with Down syndrome, as well as cystic fibrosis, I believe. They have different growth parameters, so that's important to know if you have a child that you're taking care of that has Down syndrome or cystic fibrosis. They have different growth charts that need to be compared, and not be using the one that we use for normal developing children. And now moving on to kind of the classification system that we use for failure to thrive. There's an interesting kind of shift in the literature that's been more recent as of late, in that we're kind of shifting away from the old sort of thinking to sort of a newer sort of thinking. I'll kind of go over that in the figure below in just one sec. So here we are. So we have failure to thrive here up on the top, and I'll kind of go over this old approach at first. So the old approach, we kind of had two separate categories of an organic cause and a non-organic cause. So basically what this means is that whether we have a kind of discernible underlying medical illness that's causing this failure to thrive compared to, say, a non-organic cause. These were typically things that are more kind of psychosocial in nature, whether it be miseducation for the parent, the child isn't the child is being neglected in a way, or not being fed properly. Those are kind of psychosocial complaints that really identified the non-organic causes of failure to thrive. But now we kind of have a newer approach to failure to thrive that I think is a lot more helpful for classifying failure to thrive, as well as the differential diagnosis of failure to thrive, which we'll get to in a sec. So first we have inadequate intake of for children with failure to thrive. This is common for kids who aren't getting enough nutrition, for whatever reason it may be. Second, we have increased caloric loss. So these are kids who may have sort of a malabsorption type syndrome, in which they're intaking the milk or their nutrition properly, but they're just not absorbing the proper nutrients, leading to kind of weight loss, potentially diarrhea of that sort. And then finally, we have increased caloric demand. Like economics, like there is in the real world, we have supply and demand, and it's just the same for the caloric demand for children. So whether it be a hypermetabolic state or a chronic illness, there can be increased caloric demand for the child, leading to potentially failure to thrive in this case. And I hope you can appreciate kind of the silly drawings or pictures that I have here that help me kind of compartmentalize the etiologies, or kind of breaking down what exactly might be the cause of failure to thrive. So for baby bottle, we have inadequate intake. I got SpongeBob here. He's very porous, so we have no increased loss of nutrition. And then I put a windmill here, showing that there's an increased energy demand for kids with this type of failure to thrive. So for intake, a couple of etiologies that I kind of want to go over include GERD, so gastroesophageal reflux disease. GERD is very common in newborns. They have a very kind of not a very strong lower esophageal sphincter. They're very new to the world. Their stomachs are very, very small, making it very likely that gastric contents, milk, is going to be extruded, up against gravity, so that they're spitting it up essentially. And this may lead to some failure to thrive as well. One other thing includes cleft lip or cleft palate. If there's sort of oropharyngeal dysfunction of the feeding process, this can be very a common reason for failure to thrive. And kind of going along with that, like I said, oral neuromotor dysfunction. Kids with cerebral palsy even can have dysfunction of their palate, their tongue movements. This can lead to failure to thrive as well. And then finally, one more kind of psychosocial kind of complaint that might be there is kind of neglect. If a child's not getting enough nutrition, they're being ignored by their parent. This is a very sad kind of case of that, but something to consider as far as the intake side of things. Next, moving on to increased caloric loss. So remember SpongeBob, he's porous, he's not absorbing too much. So things like celiac disease, things like cystic fibrosis, in which there's kind of malabsorption of proper nutrition. Those can be common things, or not common things, but examples of caloric losses. One thing I think that I want to highlight that is super, super common, especially on my pediatric GI rotation, that was super, super common, is milk protein allergy. So this is a kind of an IgE potentially an IgE mediated condition in which there's an allergy that presents potentially as eczema, diarrhea, mucousy diarrhea at that, mucousy diarrhea, as well as vomiting for newborns. They don't have to be just ingesting formula that's made out of milk or cow's milk protein, but even women who are nursing and have high dairy intake in their diet, this can lead to crossing of those milk proteins into the child, thus causing potentially milk protein allergy, and thus also causing caloric loss and failure to thrive for this child. Typically, we ask mothers to kind of cut out dairy, soy, things like that in their diet so that they're not potentially being absorbed in the breast milk, for example. And then finally, leading to increased caloric demand. So remember the windmill that has increased energy demand. So things like hypermetabolic states like hyperthyroidism, things like congenital heart disease even, as well as kind of chronic lung disease, sepsis. These are all conditions in which the body is needing more energy to kind of expend, to kind of contribute to vital functions, essentially. So, for example, with congenital heart disease, there potentially is not enough oxygen getting to tissues, and thus the heart has to work harder. There's more demand on the heart, and thus kind of vital tissues are beholden to this congenital heart disease, and thus kids need more or have more demand for the nutrition, essentially. Next up is treatment. So basically, kind of getting at the underlying cause, treating the underlying cause of failure to thrive is kind of at the core of our treatment for failure to thrive, whether it be cystic fibrosis, celiac disease, milk protein allergy, GERD, those are sort of the guidelines for treating failure to thrive in this case. But a couple other things that we can do sort of in the meantime to help with, the nutrition of children is increasing frequency of feeds and also increasing the volume of feeds, especially for those newborns who are taking milk. And this only helps, especially for kids who are underweight. One other thing we can do is also increase the caloric density of formula, for example. So typically breast milk is 20 kilocalories per ounce of milk, but we can kind of fortify different types of formula that the kid might be intaking so that we can get 22 calories per ounce, 24 calories per ounce, 26 even sometimes if the failure to thrive is a very kind of severe. We can increase the caloric density of formula by increasing the amount of scoops that mom is putting in her formula for baby. And then for sort of kids or adolescents who may have food aversion, we can supplement with different types of shakes that have adequate nutrition, protein, fat, carb amounts. These can be options for kids who simply won't try different types of foods, who have aversion or swallowing difficulty, and that a shake is much more tastier to them. The texture is a lot better than, say, solid food for kids who may be aversive. And then one other thing that I think is really underrated is observation of a child's eating habits. So, we're calling in our OT colleagues, our speech language pathology colleagues, to kind of help identify potential causes of what exactly is this child's eating habits. Is there anything we can pinpoint down to how the child eats, where they eat, their types of foods they eat, so that we can observe the child's habits and kind of get at the underlying cause of this, whether it be, like I said, kind of feeding aversion, texture issues, things like that. And now kind of leading into prognosis here and things like follow-up, which is really important, especially with a kid with failure to thrive. One thing that we like to look at, especially over time, is the growth velocity of a child. So this is something that we measure in grams per day. Over time, we can have a measurement of how much a child is gaining in terms of their grams per day. And there's a great chart from the AAFP, which I encourage you all to check out. There's a sort of normal median weight gain for children depending on their age which is very important to kind of monitor to see, are they maintaining adequate weight gain over the course of when we see them. One other thing that's important is also catch-up growth. So we don't want just the child to make it back to the fifth percentile of weight. We want them to catch up and grow adequately, past that fifth percentile ideally. And this is actually, based on that AAFP chart that I mentioned, is actually 2 to 3 times the average rate in grams per day. So kind of doubling or tripling that average rate so that kids are actually catching up in their growth rather than just getting back to the kind of the lowest line on the growth curve. And then, as far as follow-up goes, especially for newborns or infants, we want to see these kids more frequently, kind of on the measurement of weeks rather than just months. These children, newborns, infants are at their, they grow. Their rate of growth is very fast. Therefore, we want to see them have adequate nutrition when they're in this kind of period where growth is the most increased, essentially. And then as far as kind of adolescents or children, school-age children, we'll kind of see those more on the kind of month-to-month basis. Obviously each child is sort of individualized in a way, but that's sort of one thing that's a general guideline. We see infants and newborns much more frequently than children or school-age children. In the instance that they're not, red flags that kind of raise alarm bells, if treatment is not working, if we see sort of, or one thing that I saw in the literature was that, if there's not adequate an acceleration of growth for 4 to 9 months, then treatment is, not working. We need to try something else. There are times when children can be abused, neglected, have traumatic injuries. If there's very serious malnutrition, these may be signs that we need to, hospitalize a patient for potentially NG tube feedings, G tube feedings, and this is where we consult surgery, kind of to help us manage this so that they are getting nutrition, one way or another, if they're not eating, essentially. One other thing, as far as kind of prognosis, that's very interesting. That's not super well studied in the literature, actually, but there is linked to neurodevelopmental disabilities, behavioral difficulties that may plague children if they're not getting adequate nutrition, especially vitamins and minerals. Those might be deficient. IQ has even been linked, decreased IQ has even been linked to failure to thrive. So this may plague children later in life, especially if failure to thrive kind of persists beyond, if persisting beyond 2 years of age. If we see them, in birth and they're still not, gaining adequate weight by 2 years of age, this can be sort of an ominous prognostic factor in that they may have learning difficulties, neurodevelopmental concerns, decreased IQ that might plague them kind of future development. So I hope this video was helpful in kind of dissecting exactly what failure to thrive is, how we can kind of categorize it in your mind. And one thing that I found really, really helpful, especially, learning on my pediatric GI rotation, is this kind of approach to classifying or consolidating failure to thrive so that I have so that I can have a good differential diagnosis when it comes to failure to thrive, kind of parsing out what kind of factors are contributing to failure to thrive. So I hope this video was helpful, and thanks for watching.